All right. Well, it is my pleasure to introduce our neurosurgery fellow this year. That is Dr. Herika Negri Brito. Dr. Negri Brito hails from Recife, Brazil, where she did her original training and residency. And then more recently, she has done neuro-oncology fellowships at the Cleveland Clinic and a spine fellowship at Mayo here in Arizona. And then this year, she's been with us learning all there is to know about pediatric neurosurgery. And so her talk today will focus on ventriculomegaly in infants. And this is actually a project we started together utilizing the fetal care database we have here at Phoenix Children's. So I believe much of her data will come from our patient experience here. So thank you, Herika. It's been a pleasure to have you. I look forward to your talk.
Thank you. Thank you for the kind introduction, Dr. Bristow. I'm very happy to be here, and thanks for joining me today. So talk a little bit more of ventriculomegaly in the infants, this kind of whole world, reveal a little bit of the diagnosis and causes. So this is one of the learning objectives. We're gonna discuss just the common causes of ventriculomegaly, a little bit of its pathophysiology, some overall knowledge and imaging as I kind of go and I explain a little bit more. I have some cases to display and also review some of the treatment approaches to that. I have no disclosures. So I try to kind of divide a little bit between the prenatally and postnatally ventriculomegaly, but it's kind of, you can see that it's sort of a continuum. So as we identify that in the fetal life, most of the babies that we start still following after their birth. So you will also see that most of the causes for that are also going to be some that we identified in the fetal life. We kind of keep following as the baby is born. So some of the things that can kind of define that is basically whenever you find an atrial diameter of the 10 millimeters or more on a prenatal ultrasound between the second and third trimesters of pregnancy, that's when you have the ventriculomegaly. There's usually some interchangeably, like in terms of the hydrocephalus and ventriculomegaly. Hydrocephalus tending to be more like when you have some raised intracranial pressure, as well, whereas like ventriculomegaly is pretty much just the size. Most of the cases, then also the cases that we see here, and then we have follow here in a prenatal, the fetal center is basically from a mild fetal ventriculomegaly, which is pretty much like incidental and benign. Most of the cases, we don't have to do anything. Some of the cases can be associated with some genetic and structural, even cognitive disorders, as we've seen, and as I kind of show a little bit more of that. So this is the first case that I'd like to show. This is a patient with that we didn't have any to shunt. This was a G2P1 mom. This is the MRI at 38 weeks. There was a lot of some findings as a polymicrogyria, absences of the corpus callosal, some heterotopic gray matter, and also ventriculomegaly. And postnatally, the MRI at 3 months was stable. This patient developed epilepsy and then required a hemispherectomy for that. But still, there was no need for shunt at 3 years of age. This is the other MRI. This is the other case. As you can see, this is like we saw ventriculomegaly before. We see now ventriculomegaly again. This was a termination case. This was 27-year-old mom. The obstetric history was a no. And you can see the MRI at 26 weeks, a pretty large, like a severe ventriculomegaly with 30 millimeters, sorry, of the size of the atrial. And then it was pretty much a severe ventriculomegaly only, and this pregnancy was terminated. So again, when you talk about the size of the atrial, you can see that we can divide it off like in 3 categories, pretty much like a mild between the 10 and 50. Mild, it depends on the literature, 10 to 15 or 10 to 12. You can have like a moderate size of the ventricle, 13 to 15 millimeters of the atrial size, or even a severe ventriculomegaly when it's more than 15 millimeters of size. Also, the mean values of that, depending on the technicality of the ultrasound, can range from 6.2, more or less 1, to 7.6, more or less 0.6 millimeters. But while we do this in the second and third trimesters, probably because it's not going to change much. So that's why we use this baseline. Usually, because of that, we cannot diagnose before the 15 weeks of gestation, and the prevalence of ventriculomegaly is pretty much up to 1.5 in 1,000 births and pregnancies. So some of the etiologies we can have either from obstruction of CSF outflow, CSF hypersecretion, loss of destruction of the cerebral cortex as hypoxia ischemia, some metabolic causes, as part of genetic syndromes that I've discussed about like a little bit before. Just recently, we had a baby that we had some suspicions of Gilbert syndrome too, which can also be accompanied by hydrocephalus. So some of the diagnoses, coming back a little bit more of the role of the ultrasound there, it's very much because it can be measured in the transventricular axial plane. Here we can see in the image the level of the frontal horns in the cavern and septal pellucidi, and then which you also have the cerebral hemisphere, which and pretty much symmetric appearance. And then because of that, we can, when you put the probe on an axial position, you can have the measurement done. So why again, like the ultrasound, this is usually the first method of imaging that we're going to use throughout pretty much the whole pregnancy. Also, the atrial is the first area to dilate in the fetal ventricle. It usually dilates to a greater extent to any other region of the lateral ventricles. Also, the atrial dimension kind of remains constant, as I said before, between the 20 and 40 weeks of the gestation. Some of the walls there are perpendicular to the ultrasound beam in the transventricular plane. So that measurement has a low and an inter-observer variability, meaning that if pretty much like 10 people kind of do this measurement, we have very low variability in terms of the size of the atrium. So whenever you find this, there's some workup that needs to be done. Usually go with history and imaging and genetic. So history, some of the things that we do pretty much with everybody that we can find some sort of like anatomic or even a anatomical variability, some history of consanguinity. If the mom has any previous pregnancy with the same malformation, any other child with a malformation, some neurodevelopmental delay. There are some mutation in L1 CAM, which is pretty much an X-linked hydrocephalus, which is pretty much associated with the males. And then the L-con is usually, it's a neurosil adhesion molecule and then plays a critical role in the neurodevelopment. So this is something that must be looked for too. Also for imaging, target the scan of the spine, our areas, and in all cases of ventriculomegaly, you can always find some of the spine changes associated with that. You can also look for hepatosplenomegaly, ascites, some intra-abdominal calcifications, all other structural anomalies that can be part of the several genetic syndromes. And then up to 76% of the cases, you can find some of the other these other findings alongside with the ventriculomegaly. And also genetic risk of trisomy 21 increases by a likelihood ratio of 3.8 whenever there's a structural isolated IVM ventriculomegaly diagnosed. So most of the three things that we have to be careful and look for. And also we talked about ultrasound, but is there any role for the MRI? So if you have a very experienced radiologist and doing the ultrasound, there's a little role for the MRI, very much because you have all of the information that you need through the ultrasound, and that would be very accurate. Some other facilities where they don't not have the neurosonogram available, so the MRI would be a good thing to do. Also, the MRI has the advantage of diagnosing some of the cortical migration abnormalities that you cannot see with the ultrasound. Also, some small hemorrhagic foci that are not impeded by the calcareal shadowing, or in cases of maternal obesity, some of the fetal position. That was kind of some of the things that where the MRI can help. talking a little bit more about the PCH Center for the Fetal and Neonatal Care. This is where we got the data for our research here. So that center was established in 2013, and it offers multidisciplinary medical surgical service. There's a care coordination and on a wide variety of prenatally diagnosed conditions. And you can see that the number of referrals have been steadily growing up, like and increasing since the last at least 11 years. And also the number of visited hydrocephalus, kind of some years we have lower, and some years you have like more visits up to 23. We had a little bit of a decrease in the amount of visits. We still have the number for 2024 to come. So basically, what you have in the center is that most of the patients that will come in will undergo a neurosurgical consultation to discuss current image findings shortly after diagnosis. The routine follow-up is usually not required in the prenatal period, so it's one visit. We're going to go over like the results of the ultrasound or any other imaging, and then establish care with the patient and the family. If there's an advanced node of the delivery of the date, it's requested for any potential surgical planning. Infants with severe microcephaly or with suspicion that need immediate intervention, that they will be transferred to the PCH immediately after birth. And then some unstable infants with normal cephaly, they'll be observed a little bit at that delivery hospital, refer as outpatient for follow-up, but sometimes we do have calls that from the outpatient from other hospitals, just because they found out something or if the patient was followed by us and then the baby is born elsewhere. We're happy to have the babies transferred here so we can take care and then follow up and keep following. This is another case. This is a case that was stillborn and term. This is a 37-year-old mom, G4P1. This patient had an MRI in 24 and 36 weeks, and you can see that sort of like also severe ventriculomegaly. There's also some other associated changes, that's congenital diaphragmatic hernia, bilateral ventriculomegaly, and cerebral hyperplasia and VSD. There was an amniocentesis performed and then a deletion of P1P36. So this is where you find most of the genetic causes also associated, and then parents are planning and comfort care only. So some of the prognosis here, most important factors and severity, the severity of the ventriculomegaly and associated with any other structural and genetic abnormalities. I'll show a little bit as we go over the data that we have here, that in a true isolated ventriculomegaly, most of the outcome would be kind of correlated with the degree of that dilation, but also some of the isolated and most of the isolated ventriculomegalies that we found here, when they were very mild, most of those babies didn't need any of the treatment at all up to until 6 months of age. Some of the babies that have ventriculomegaly, even if it's mild and associated with other type of structural genetic abnormalities, those were the cases that would necessitate some sort of treatment right off, like between the first month and the 6th month of life. So whenever you have an atrial diameter of more than 20 millimeters, this is a high correlation for the shunt. We can see this here in our practical and then daily life of seeing these patients and office. Also, the survival rate for the fetuses with a mild moderate ventriculomegaly was reported between the 98 and 80% respectively. But overall, we can see that more than 90% of these fetuses with isolated mild VM, they will have an isolated moderate lidation and also have a normal neurodevelopmental outcomes. The prevalence of these CNS abnormalities significantly higher than symmetric ventriculomegaly when comparing with the asymmetric ventriculomegaly. You have almost 40% versus 24% of all CNS abnormalities. And most of the cases, when you have severe ventriculomegaly that are associated with informative neuroextracranial anomalies, in general, the prognosis is very poor. As you can see, some of the cases before, and we have like intrauterofetal demise or even an interruption on the pregnancy. Most of the time, it can be up to 33%. So because of that, we decided to do, and because we have a fetal center, we decided to collect a little bit of more data and begin with this ventriculomegaly pilot study. Because we are a referral center, all of our data is very biased, but we can have some inferences from that. So some of these stats here for the program, we had almost 9,000 referrals between 2014 and 2023. To the last year, we have 1,312 referrals. 66% that we returned to the PCH, 6% of those expired. We lost a follow-up about 6%, 1% is at manner, 18% were unable to find actually. 2% were terminated, 2% still pending delivery. This is all data from the last year. Of those, we had fetal MRIs up to almost 300% and an increasing since 2022. We had almost 400 fetal consults with neonatology, up to 88% from 2022. 68 fetal neurology and neurosurgery referrals, up to 31%, and 105 fetal palliative care referrals, up to almost 60% from 2022. And among that, 47 fetal genetic consults. So it's been steadily increasing, and then more and more, we have been more and more busy. So we're able to find for this pilot study about 43 patients that were included between 2013 to 2023. The amount of patients now in the data is, I would say that's pretty much close to 200. I think we'll be able to close the data in maybe 250 patients. That would give us more like a power, like in terms of size, and so we can make all the calculations that we need. And the mean ventricular size for that was 28 millimeters with a standard deviation of 0.94. That's why I said that, I mean, we know we have like a lower number of patients, but also our data is a little bit biased. We had a cutoff size for hydrocephalus and ventriculomegaly, as we said in the literature, more than 10 millimeters, more equal 10 millimeters. We have that most of the patients that we saw for this pilot study had only ventriculomegaly. Some of those was ventriculomegaly to neurotube defects, some Chiari, CNS malformations. In red, you can see that some of the patients had ventriculomegaly plus chromosomal abnormalities. And the small number of patients had ventriculomegaly is associated with a congenital heart. So when we look for time to treatment and the type of treatment that we had done for this initial 43 patients, we divided between the first week of life, first month, and more than 30 days. So most of the patients were in the first week of life. And inside the first month, we have about 11.6%, and more than 1 month of age, 11.6% of the patients too. The majority of the patients underwent shunt only as treatment, 2.3%. We did the ETV, that failed, and then ended up in a shunt, and about 7.1% we did ETV only. The ETV only patients, that 7% were the patients that did not require shunt later in time. So when we look a little bit at on mortality here, in our series, we had a high mortality rate of 34, almost 35%. Also, severe ventriculomegaly was associated with a high risk of neonatal mortality, about 16%. Even in the absence of any other prenatally detected and associated anomalies, you can see that the terminated pregnancy is colored orange, light blue with stillborn, and also the darker blue. We tried to do a logistic regression analysis here with the initial 43 patients when comparing treatment prediction versus ventricular size. And then we can only see that as the ventricular size increased, we had a tendency to treat that patient, either if it was like a shunt or an ETV or even like both. That number is still very low, so we can have like a more of a powerful association here, but it's kind of also a little bit of very rational kind of finding. And then when we divide those the data between the days that we did the initial treatment during the first week, first month, and after a month, most of the patients were treated in the first month. But also you kind of compare the first week and then within the first week of life and within the first month of life, within the first week of life, we have up to 0.09 increased size in the ventricles. We tried a little bit to see if our ventricular size cutoff for treatment of 36 millimeters was important. We can see here a receiver of operating curve here. We had a result of 0.6, which means that we can kind of interpret that, and then about 60% of the time we are right in predicting that as a size cutoff. I agree that's kind of very large, like a very large size in the ventricular size of the ventricle, but also with a small amount of patients that we had in the beginning. I think that once we kind of get a little bit more in, like with increase the number of patients, that ventricular size cutoff will be decreased. And also, we did also another logistics regression and ventricular size and death probability. And we found that as ventricular size increased, we had the odds of death also increase in about in a p about 0.06. One can say that's not very significant since it's still greater than 0.05. But when you kind of extrapolate those data to the clinical analysis and to our like kind of our daily like practice of neurosurgery, this is still very important. And it means like whenever you have like a very severe ventricular size, that will probably mean that baby or that fetus is in a there's a very high risk that that pregnancy will be terminated and we have a stillborn when the pregnancy is finished. This is another case of shunt at birth, and you can see here it was a 26-year-old mom, G2P1, MRI at 21 weeks, aqueductal stenosis, some foreign cyst, the genesis of the corpus callosum, disrupted septum. Postnatally, the OFC was 44.5, about 97 in the 97% percentile. This was a case of shunt in day 2 of life, and then following up the patient, this patient he ambulates and feeds normally, but is non-verbal at the age of 3 years. And you can see here with a little bit of more details, all the findings in the MRI. So moving up a little bit, like for postnatally ventriculomegaly, again, we have a little bit more of difference in the measurement. So there's the ventricular index and then the atrial horn width, both obtaining in a coronal plane to the anterior fontanelle at the end level of the foramen of Moro. And also most commonly used, those are the most commonly used measurements, and also to define and also grade the neonatal ventriculomegaly. Also, there's again ventriculomegaly, hydrocephalus, kind of terms that can be combined. We tend to use hydrocephalus whenever we think there's more than just the increased size of ventricles, but also some sort of raised intracranial pressure. Again, the etiology is pretty much similar to prenatal ventriculomegaly. We have the congenital causes, as I said before, the X-linked hydrocephalus that's linked to the L1 CAM mutation, fourth ventricle obstruction, then the Walker syndrome, congenital atresia of the foramen of Moro, other disorders of organogenesis. We have also some acquired, you can see like inflammation, intraventricular hemorrhage. I would say that's pretty much most of the cases that we see as an inpatient, like daily basis, and then also as reason for transferring from other hospitals here to the PCH. Neoplasm also is another cause. We recently had a baby, 3-month-old baby diagnosed with a choroid plexus papilloma as a cause for the hydrocephalus. some of the destructive process leading to ventriculomegaly and even vac hole, bilateral or lateral vascular causes LLC, as I'll show you in a few more slides. Also, that could be causes for hydrocephalus, and also any other craniofacial syndromes such as Cruzon and Pfeiffer, which are pretty common here in our practice too. So some of the physiology of the CSF production and circulation. So in the past, we used to believe that as we can see here in picture A, most of the CSF circulation is just like choroid plexus, and then they're going to be absorbed to the arachnoid villi. But then there's been some like newer theories regarding the CSF circulation, which before going for a new unidirectional flow in the figure A, you can see in figure B more than it's probably going to be, the CSF is going to circulate all throughout the neural axis, and not going to be not only in a unidirectional flow from the choroid plexus to your arachnoid villi, but also you can see there's some of the new structures that have been studied and also being kind of related to the CSF circulation. As you can see, the glymphatic system, which is a new system that's been identified, and then in terms of it helps with the CSF circulation. And also we found out that some of the aquaporin and 4, those are the channels that could be in the pia mater, and then also help in the CSF circulation all throughout the neural axis. The glymphatic system, the new glymphatic system, also functions in the cleaning of the debris that we accumulated in the central nervous system. It's been found to have some implication with Alzheimer's disease too. And also it's been studied that the glymphatic system operates better throughout the night. So instead of having that sort of like unidirectional, we have a whole system of glymphatic system, aquaporin channels, also some of the lymphatic channels going on the meningeal, help with the CSF circulation. The fact that systole and diastole kind of helps with that too. Those were all the things that are a little bit of newer findings, and those recent findings help us understand a little bit more of how the CSF production circulation happens, and how that would be impaired in most of the patients that we're going to be following. So again, as I said, like not all cases are going to be like from congenital structural abnormalities, but this patient is still one of the patients that we're following. The case of still no shunt ventriculomegaly due to a vein of Galen malformation. It was a female born in 24 weeks, 6 days. We decided to embolize with the help of the IR team. So she had an embolization of the two BCA feeders on February 26. We've been following her with the daily measurement of the head circumference. We're now doing weekly cranial ultrasounds, and then her head circumference has been decreasing steadily, and she was in the 97 percentile up to the 53 percentile now. She's been very stable. We're probably going to be following up closely up to the 6 months of life. If the head starts increasing in size again, if she starts to develop overt signs of hydrocephalus and increased intracranial pressure, that's probably be when we're going to decide and shunting her. But as for now, since the embolization, we're trying to give her a little bit of time and see how that CSF that I just went a little bit about, that all the circulation and it's going to be rearranged, and then we expect a little bit more and then see how it goes before deciding on shunting her. So most of the cases that we get here, most of the babies that we're going to be following are due to post-hemorrhagic ventricular dilation. So IVH occurs in up to 25% of the infants with very low birth weight, to 25%. So IVH will develop that ventricular dilation. Most of them will resolve on its own, and about 35% will require some form of intervention. We know that the post-hemorrhagic ventricular dilation is kind of multifactorial. We have obstruction of the circulation at CSF, secondary to clotting of the aqueduct. We have impairment of that circulation too, pretty much because you have arachnoiditis. We have also disturbed resorption of the arachnoid valley. And also white and gray matter loss, they contribute a lot to the enlargement of the ventricles as in a ex vacuo manner. Also, this is the most difficult in terms of treatment for us. I'll talk a little bit about ETV, ETV plus CPT versus shunt. And most of the cases babies with the IVH, because of all their impairment in circulation and absorption, that also complicates our treatment too. And then IVH and then that PHVD also induce the resorption of the subventricular zone of the germinal matrix and then impair the migration of the progenitor cells. That's why most of the babies will have neurodevelopmental issues in the future, or even like development of autism or any other kind of any other type of problem. So this is some of the like a very quick reviews of some of the treatments that were proposed for the PHVD. We had two studies that used diuretics, furosemide and acetazolamide, and a carbonic anhydrase inhibitor. They were compared there was a comparison in using those drugs versus conservative treatment or lumbar puncture. There are some conflicting results here, and then regarding the reduced need for the VPS shunt, for the ventricular shunt. But there was a higher mortality and worse neurodevelopmental outcome in the group that received the diuretics. So there was consensus that acetazolamide, furosemide, not recommended to reduce the need for shunt placement with the infants born preterm and post-hemorrhagic ventricular dilation. This was a level 1 recommendation. Also, there was another study that used phenobarbital to see if they could stabilize blood pressure and prevent early systemic and cerebral hyperperfusion and as a high risk factor for IVH. And then according to the most recent Cochrane review, the evidence about the effects of prophylactic phenobarbital treatment versus control, no intervention, and even in placebo on IVH and also ventricular dilation, mortality and neurodevelopment were all uncertain. So also not a recommendation to use that. We have like a lot of different methods to remove CSF, lumbar puncture, temporary devices such as Maya reservoir, any type of ventricular access devices, external ventricular drains, ventriculosubgaleal shunts. Those are all treatments that you can have. There's also another paper that described the drainage irrigation and also fibrinolytic therapy. There was a study in a randomized trial that compared the intraventricular drainage irrigation and fibrinolytic therapy with a tissue plasminogen activation versus standard treatment, considered mostly as CSF tapping to control the expansion of the ventricles. And that study was stopped early after analysis because there was minimal chance of demonstrating difference between the groups regarding the main outcome, which is pretty much shunting or death. But also there was a increase in the rate of secondary IVH just because of the use of the TPA. So no recommendation for that either. There was also another study that kind of compare a little bit of early versus late intervention and post-hemorrhagic dilation here. So basically, they compared preterm infants with post-hemorrhagic ventricular dilation, and with the outcome of death or severe neurodevelopmental disability. Multi-center randomized, they kind of divided those patients in the lower threshold when anterior horn width was more than 6 millimeters, and also a higher threshold when the anterior horn width was more than 10 millimeters. And there was, again, the composite adverse outcome was defined as death or cerebral palsy, or also cognitive and declining cognitive and motor scores when the patient was at 2 years of age. And we can see that the outcome was about around 35% in the lower threshold group, and compared to 51% in the higher threshold group. Also, in the lower threshold group, the intervention, which is the lumbar puncture, was associated with a decreased risk of an adverse outcome when correcting for that gestational age. And infants with a favorable outcome had a smaller front-occipital horn ratio too at term. So, and then a post-hoc analysis for that study, the early intervention was associated with a lower odds of death or even severe neurodevelopmental disability when that those children reached 2 years of age. So as we can kind of extrapolate that, as when you see that kind of severe ventricular dilation in preterm infants with posthemorrhagic ventricular dilation, it means that if the sooner you intervene, the better for the patient in the future. So general options here for the treatment hydrocephalus that we saw in our in our pilot study. So VP shunt, long-standing treatment, ETV plus choroid plexus cauterization. It's a relatively new intervention, wide range of vasectomies. But when we compare the both techniques,
Here is, and then 5 days rolling. Oh, and
success rate for the PPS in pediatric hydrocephalus reported to be around 86% in a median follow-up of 41 months. Success rate for ETV, kind of more or less the same, 81%, with a similar median follow-up of 41 months too. But ETV tends to have a lower complication rate at about 4.6%. But when you come together, ETV and choroid plexus cauterization, overall success rate of 59%, and success rate are kind of vary by etiology. Most of the cases when you have aqueductal stenosis, that's when or myelomeningocele cell, that's when you're going to do most of the success. 64% for post-infection hydro, 52% for post-hemorrhagic hydrocephalus. As I said before, that's IVH is kind of the more difficult that we have in terms of treatment for the in terms of offering treatment and have the patient treated as infant in the first year of life. So you again, another thing that we can do that's ventriculosubgaleal shunt. This is a patient that we're also still a little bit following. It's a 20-weight male transferred at 21 weeks from outside hospital for neurosurgeon consult due to increased ventriculomegaly plus seizures. You can see here in the measurements that he has severe ventriculomegaly and then hydro. And also you can see in the picture here that we ended up doing a ventriculosubgaleal shunt. This is the incision here. You can see like a bump, the little bump from the shunt. This is something that we have to take care and then be careful of those babies because they have very soft baby skin, very thin. Most of the time they will be even less than 2 kilos in weight. And then we have to be very careful with that incision and wound healing. If those things break, the majority of the patients would be infected. And the only thing that we do not want is an infection on those babies. So then again, ventriculosubgaleal shunt, and then why that? Why not shunting? And why that? How can we predict the success of ventriculosubgaleal shunt? So there was a study published in 1992 that study basically they found out the cutoff size for the cortical mantle thickness that would predict the success of the ventriculosubgaleal shunt. So that cutoff is 1 centimeter, meaning that whenever you have that mantle thickness less than 1 centimeter, that was associated with the catheter movement, and also that could impact the accuracy and effectiveness of the shunt placement. Basically, at least a cortical mantle thickness of 1 centimeter, so you can have a placement of the ventriculosubgaleal shunt. And if we come back here, we can see that the cortical mantle is pretty thick. So that baby, that ventriculosubgaleal shunt is working pretty well, and the incisions healed well too. Again, this is one of the abstract that I presented in the last joint pediatric session in New York last year, where we compared the efficacy of ventricular subgaleal drainage, meaning neonatal hydrocephalus, with the IVH. That was a systematic review analysis, where pretty much went from studies since 2000 to 2024. Eligible studies, we included pretty much those with more than 4 neonates, focus outcomes, including infection, ventricular subgaleal shunt revision, migration obstruction, CSF leak, permanent shunt, mortality, and related mortality. We ended up with more than 500 patients. Infection rate was about 90%, 9%. Revision of the shunt in about 4%. Obstruction was seen in 2%, and the migration rate about 1%. We did not have the cortical mental that I just mentioned. That was not included because we didn't have that data on other studies that were included for that. So we do not know why the obstruction and migration, why did that really happen. Analyzing also CSF leakage, we found that presenting 6%, but patients ended up in a permanent shunt placement in about 75% with a mortality rate of 10%, meaning again that IVH is very difficult to treat without a permanent shunt. So baseline, bottom line, it's an effective procedure. If treatment for the hydrocephalus is required in very low infants, attention to the cortical mental thickness. If you want to buy some time, let's say it's a patient less than 2 kilos that you do not want to shunt, you're going to give them time and see if it improves. That could also be done. And an alternative would be like a reservoir, like a Ommaya catheter, where you can just put in and keep tapping the patient. This is also another article that mentioned the natural history of fetal isolated ventriculomegaly when you compare pre and postnatal imaging. And pretty much in cases when you have at least one dilated ventricle, in a normal workup, like serological tests, detailed anatomical scan, fetal brain MRI, genetic counseling, those were considered idiopathic ventriculomegaly. Those are the cases that you do not have to do anything. Most of the patients, about 24 months, that ventriculomegaly is going to be resolved on its own. So that study indicated that significantly regression of the prenatal isolated ventriculomegaly and postnatal period. And that's somewhat what we found so far in our pilot study. But in our pilot study, most of the cases where they have isolated ventriculomegaly, they were very mild, meaning that they were up to 11 or 12 millimeters in size. So again, this is a case of IVH, no shunt. This is also a patient that we've been following, a 2-day-old female that came in full term respiratory distress. In IVH, we can see that some degree, and also you can see the bleeding in the ultrasound and also MRI. We've been following with a serial cranial ultrasound and head measurements, and that patient was fine in the end, didn't have to do any intervene in any way. Also another case, this from our cohort on shunt at 5 months, 30-year-old mom, G1P0, MRI 33 weeks, received ventriculomegaly only. Postnatally, a high RFC, accelerated up to 50 at 5 months of age. So there was a shunt was done, and 17 months the patient was walking, saying a few words, and fingerprinting himself. So a little bit of discussion here for the prenatally ventriculomegaly series. In our series, the majority of patients treated within the first week of life had more comorbidities, meaning that they had more neurotube defects, they had more congenital heart problems, apart from the severe ventriculomegaly. The other group that we treated in the first month of life, it's about 8 to 30 days, had a mean of 0.09 times larger ventricular size when compared to the group treated and within the first week, but they did not have a lot of other comorbidities as we find in the first group. And also our series so far had a greater mortality rate when compared to the literature, but probably related to a small sample size. Also from our series, we found that the ventricular size cutoff of 36 millimeters to be the size for the treatment. Again, this is a very very large number. I don't think that's going to be once our number is increased. I don't think that's going to be repeated as size. We'll probably have like a lower cutoff size for that. But also, interestingly, apart from that being like a large number, up to 50% of the patients did not require any treatment at all. Those patients that didn't require any treatment were like ventriculomegaly only. There's some specific balance and dynamics of the CSF and the fetus that was still kind of obscure. One can argue that, okay, we're finding ventriculomegaly in utero, why not treat it? Because there was a study done before where we tried to treat patients in utero for ventriculomegaly with some sort of diversion, and that was terrible. That didn't resolve the hydrocephalus ventriculomegaly, and then just kind of brought more infection to the patients. And you know that some of the CSF dynamics maintain mainly in the minor CSF pathways. So we have now the whole new network of CSF production, reabsorption, circulation, perivascular space. All of those are very linked to each other. And also when there's a premature development of the superior sagittal sinus. So the major CSF pathway develops after the baby is born. Also some physiological aspects of the intrauterine life, such as intrauterine pressure, gravity, increased intravenous pressure in fetal life compared to the postnatal. Those are all things that influence in the CSF circulation after the baby is born. So in our postnatal review, the neurodevelopmental prognosis of infants with isolated mild ventriculomegaly without any other risk factors is not different. So if you find one of those patients, those will kind of develop pretty much normal as the normal population as any other kid that doesn't have any sort of ventriculomegaly. Hydrocephalus due to the IVH is associated with higher rates of long-term disability, including like cerebral palsy, sensory problems, cognitive deficits, behavioral problems. We can see this in our like daily life and in our practice here. MRI also is a key diagnostic tool to accurately find the extent of brain involvement. Also, we can check other development anomalies leading to ventriculomegaly and provide a few understanding of that pathology. Cranial ultrasound, non-invasive tool help us a lot and follow up with those patients. Also help us define a little bit of the etiology of the ventriculomegaly and threshold for intervention. We follow this patient here. We probably have like a weekly or twice a week ultrasound that will pretty much guide our treatment for the inpatients. And then in our practice, we recommend the daily head measurements, also at least weekly cranial ultrasound when following an infant with IVH. Some of the take-home message here on that infant diagnosis ventriculomegaly is still a challenge. Linked to multiple comorbidities can change the child's life very drastically. In our series, there was a tendency towards treating the first week of life if there were other associated pathologies, as we saw before. More than 50% of the infants diagnosed with ventriculomegaly will stabilize or have a spontaneous resolution. So I extrapolated a little bit to the clinical practice that infant diagnosis of ventriculomegaly can be followed with serial head ultrasounds or any other sort of imaging, head measurements more closely in the first 6 months of life. That's pretty much the time that we have to define that. The cutoff size, again, in our prenatal series is still non-significant. It's too large, non-significant. We'll probably have that kind of change once we have a large number of patients included. But we try to develop like a predictive model for early intervention, meaning that, okay, we see a kid with let's say that ventricle atrial size of 15, that's when you know that you probably have to intervene earlier versus when you have like a patient that has multiple other comorbidities after the patient is born. And also in the postnatally review, increase in the ventricular size and also the size of the head can be safe predictors to the treatment, but I would say that they're still the best treatment option is at the discretion of the surgeon. Those are my references, and thank you very much. Let me stop sharing.
Thank you for that nice overview, Herika. And for those of you who don't know kind of what the whole data set looks like, there are loads and loads of babies referred for ventriculomegaly, and so we're now expanding our cohort to try to capture more of those and weed out the ones that really don't have true hydrocephalus or anything that requires treatment. But thank you. That was a nice review.
Thank you.
Herika, beautiful job. I'm curious for the audience here, particularly our colleagues in neurology. I'd love to hear what your take is from a non-surgeon's perspective on the variety of topics that were touched on by Herika, particularly the relevance of antenatal ventricular caliber, interventions for preemie IVH. I'd be really curious to hear what the group's thoughts are. Ventriculomegaly is a very common diagnosis that we see postnatally as neurosurgeons, and the vast majority of those children do not have hydrocephalus. And so I think that what Herika's data set really shows us is the same thing, that the majority of ventriculomegaly being diagnosed antenatally, because we're getting better, we're getting more sensitive, and our detection techniques are probably not hydrocephalus, or at least not imminently needing to be treated hydrocephalus. So curious, what the group's thoughts are here.
Hey there, great job, Herika.
Thank you, sir.
Valuable comments, Jay. I think the value in these consortia work are really to spread experience and knowledge across all the different centers that are trying to understand what the best management and treatment of this, and certainly the issues regarding ventriculomegaly and then identifying hydrocephalus that requires intervention has definitely evolved and been shaped by the hard work and by all the investigators that contribute valuable data to this. We're fortunate here to have dedicated teams that manage the babies antenatally and prenatally, and this is one of the more common reasons for prenatal consults is if the ventricles are large. So it's definitely a team approach, and we value the collaboration with our neurosurgical colleagues when big ventricles are identified to work to decide what the underlying etiology is and then decide on the best approach. I know there's always ongoing discussions. Sometimes it's an obvious decision or not about a third ventriculostomy versus placing a shunt, and then the evolution over time to using programmable shunts versus static shunts. But all these decisions are definitely best approached by a team, and we're fortunate to have a great team here.
For neonatal neurologists, one of the debates of the last, I'd say, couple of years has been the Elvis work. Well, there's a couple, I guess. There's been the Elvis work. There's been the early versus late. So the early versus late intervention, right? So there's that. There's the endoscopic lavage work that was done by Ulrich Tamali out of Germany. And then there's the drift work that was done originally, I want to say, out of Bristol, UK, with bilateral external ventricular drains and fibrinolysis and continued drainage to try to get all the sort of ventricular irritants that we think exist in IVHers out. And I think those are some of the hot topics right now in preemie IVH. The reason why surgeons have been so gun shy about early intervention is that the greatest risk factors for multiple shunt revisions over a lifetime are the age at which a shunt is placed and the etiology, which is preemie IVH, being the highest risk. So it's like we're balancing as surgeons this idea that, well, if you intervene earlier, maybe there's a better neurocognitive outcome against if you intervene earlier in preemie IVH with a shunt, there's a higher likelihood of lifetime revisions, which is, sort of a sequential additive morbidity to these children. So I'm kind of curious if, our neonatal neurologists have a take on preemie IVH.
This is Kara Lewis. Thank you, Jay. And thank you, Herika. That was really, really good. I just enjoyed it very much. I'm not a neonatal neurologist, so that part of it I would leave to somebody else. But from the fetal neurology part of it, your talk was very helpful and just kind of highlights the teamwork that's essential. And so I see a lot of these moms coming in with the ventricles at the 12 millimeter, the 14 millimeter, 16 millimeter, and above a certain level, they're also always seeing fetal neurosurgery, which is great. And the families are just very helpful, very happy to have the combined combination of opinions, and we work really closely together. That's been good to kind of know that. And so I liked this talk to kind of talk about what the various options are and what happens to them afterwards. And I think that there's probably a lot more, especially with the volume of consults that we're doing now. There's a lot more that the research that you've started can continue, and we can get even more information on sort of the longer term outcome of these families, especially the ones who didn't end up getting shunts, and we can see what their neurocognitive results are. So thank you for all of this.
Thank you.
Great job, Herika. Fantastic. Thank you.
Thank you, sir.
Thank you very much.